Welcome to Today in Psychiatry, a continuing education service presented by Abbott Laboratories to provide commentary on important issues and innovations in contemporary psychiatry. The time-conserving format of this program has been planned to help you gain the greatest possible amount of clinically useful information in minimum time. The program materials include an audio cassette and accompanying booklet. The cassette contains 4 reports on research and interpretations in psychiatry recently done by prominent clinicians or researchers. The reports are condensed so that you will be able to rapidly absorb the essential concepts. The booklet contains an outline of main points for each report on the tape. We think you'll find that following the outlines as you listen to the tape will reinforce your grasp of the key concepts. At the end of each report, we suggest that you turn off the tape and test your comprehension of the material by responding to review questions in the booklet. Or, if you prefer, you may listen to the entire cassette before responding to the review questions. In some subject areas, you may prefer to listen to the cassette without referring to the booklet. The first of our reports concerns the psychiatrist's role in dealing with terrorism. The person who barricades himself and threatens suicide or murder of a hostage is unfortunately not an uncommon problem in today's society. Incidents of this kind happen in small communities as well as large ones, and when they do, law enforcement officials frequently turn to the nearest psychiatrist for help. It shouldn't seem surprising that the psychiatrist is frequently called upon in these situations. Police authorities are likely to perceive the person making the threat as suffering from a psychiatric illness. And in keeping with our societal confidence in specialists, the police tend to assume that a specialist in psychiatric disorders may be best qualified to help. Dr. K.I. Pierce, professor and chairman of the Department of Psychiatry at the University of Calgary, believes that the psychiatrist's professional insights can be quite helpful in these situations. And he believes that every psychiatrist should be prepared for the possibility that he may be asked for help in dealing with these emergencies. Dr. Pierce has been called upon several times by police to negotiate with people who have threatened violent or self-destructive action. The experiences inspired him to study the experience and views of other professionals and formulate some guidelines for the psychiatrist who might suddenly find himself thrust into this type of situation. As you listen to the report on Dr. Pierce's guidelines, you may wish to follow the graphic outline on pages 4 and 5 of your booklet.
When police ask for help from a psychiatrist in dealing with someone who has threatened violence, they are making a valid perception of the source of the problem, in the opinion of Dr. Pierce. The person who threatens violence can best be managed by applying some of the standard principles and techniques of psychotherapy. Dr. Pierce finds it useful to view terrorists and other individuals who threaten violence in terms of 5 diagnostic categories. If any information is available on the history and symptoms of the individual, it can be used to formulate a kind of working or provisional diagnosis that may suggest what to do and say in attempting to discourage the individual from fulfilling his threats. The first of the 5 categories is described by Dr. Pierce as the criminal psychopathic type. This individual is particularly ruthless because of his lack of ability to empathize with others. Hostages are used as pieces of furniture with little regard given to human suffering. However, he is not likely to have a well-laid plan or a goal that is clearly defined. This impulsiveness, plus his narcissism, another characteristic of the psychopath, offers an opportunity to a negotiator to redirect the outcome as the situation develops. This requires a rather prolonged and continuous period of negotiation, during which no precipitate action is taken and no significant concessions made. An appeal is made to his narcissism by providing access to the media so that he can hear his demands broadcast. Responsible media, taken into the confidence of the authorities, are essential, because excessive flattering of his ego may cause his attitude to harden. Dr. Pierce's second classification is the aggressive psychopath, who espouses some extremist political cause as a focal point for all the things that have gone wrong in his life, or, having a low sense of personal worth, finds it easier to accept as his own the paranoid ideation of the group. Again, as with the case of the criminal psychopath, the best tactics are patience and continuous lengthy negotiations with heavy appeals to narcissism. Precipitate action must be avoided at all costs. The psychiatrist should try to encourage disciplined control among police involved in the case. Dr. Pierce says he has found that senior diplomats who are made hostages may be expected to maintain a cool and patient attitude, but individuals snatched up at random present a major problem in management. Their behavior may be unpredictable and thereby provoke the terrorist into unwanted action. Settlement with a political terrorist will be easier if he can be made to feel isolated from his ideational group, or especially if the group can be persuaded to publicly disown him. A third classification is the schizophrenic. If his thought disorders are to be deflected, they must be understood as completely as possible. It is important that there should be no odd intercurrent events taking place that are likely to be misinterpreted by the patient. Negotiation should, if possible, proceed over a long period of time, much as in intensive one-to-one psychotherapy, without outside intervention. Dr. Pierce's fourth category is the severely depressed person. He is not likely to respond to a rational argument, but occasionally can be persuaded to postpone his aggressive act. Care must be taken not to challenge the depressive individual, because this may increase the risk of suicide, particularly in the case of the agitated depressive. While more impulsive, the agitated depressive likes to talk, and especially to complain. A listener who encourages this may be looked upon as a sympathetic person to whom he can entrust himself and surrender to. Careful choices of phrases and words may enable him to see a picture in which he is clearly represented as sick rather than heroic. In one case, Dr. Pierce talked a young man into offering the doctor a cup of coffee, which directed the youth's attention from what was taking place to something that approximated normal human behavior. Invited into the youth's barricaded house, Dr. Pierce engaged him in a long discussion until he handed over his gun and agreed to accompany the psychiatrist to the hospital. Dr. Pierce's fifth and final category consists of individuals who appear to be suffering from some type of organic brain dysfunction. These people can be assumed to have had a normal conscience, but as a result of some failure in normal development or some dementing process, a loss of inhibition is combined with some paranoid ideation. Three factors become important. First, negotiation should take place during the daylight hours, when the patient is likely to be more rational. Second, at night it is useful to keep the area adequately illuminated, as shadows may give rise to visual illusions or hallucinations, which can precipitate an impulsive loss of control. Third, talk about the past and old friends in the case of those whose recent memory seems damaged by the dementing process. Trying to negotiate in the context of the present may be threatening and is likely to precipitate violence. In conclusion, Dr. Pierce offers these general rules. First, keep talking. As long as you are talking, nothing will happen. Second, never under any circumstances, no matter how provoked, reply with a flip or insulting answer.
At the tone, you may turn off the audio cassette, turn to page 6 in your booklet, and complete the review questions. Or if you wish, you may proceed to the next taped presentation in the series. Old age is the time when people are beset by the greatest number of crises. And yet, relatively few elderly people receive intensive psychiatric treatment. When the psychiatrist does see an older person, the immediate purpose is often a matter of disposition or management rather than therapy, because the patient's problem has become a burden for others. Some therapists have been quite frank in classifying the aged as poor candidates for intensive psychiatric treatment. But a more subtle and pervading factor is the popular tendency to think of the problems of old age as different and somehow less significant than those the rest of us face. However, this is a time when many of the stereotypes about aging are being discarded. Society is learning to view its senior members as individuals. We are coming to view the older person as someone who responds to stress in the same way as the rest of us, and whose problems are likely to be reversible if he or she receives the right kind of help at the right time. One psychiatrist whose work is helping to dissolve the stereotypes is Dr. Bert S. Capel, professor in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine and consultant to the Geriatric Research, Education, and Clinical Center of the Veterans Administration Hospital, Palo Alto, California. Dr. Capel believes that popular concepts of the problems of aging as being irreversible may be contributing to the alarmingly high suicide rate among persons over the age of 65. As you listen to the report on Dr. Capel's views, you may wish to follow the graphic outline on pages 8 and 9 of your booklet.
If there is a unique quality to the emotional climate of old age, it is that several major crises are likely to be occurring simultaneously. The most common of these events are, of course, major illnesses and the decline of physical abilities. This change is often occurring at the same time as declining economic status. Even if the individual is not at the absolute poverty level, he or she may have had to adjust to a drastically reduced living standard after retirement. Anxiety mounts as the individual realizes that still greater reductions may be required in the future because of inflation. Feelings of humiliation may be added because the person has to depend on help from others. Decline of physical strength and economic power are often compounded by loneliness. Living arrangements often isolate the older person from free contact with others. Perhaps the spouse and lifelong friends are dead and acquaintances are moving away. Retirement from work often involves not only the loss of income, but loss of the status and prestige of the work role and the opportunities for contact with others that the daily work routine provided. The aging person also must face the inevitability of death. Not only is there anxiety over his or her own eventual death, but often a state of continuous bereavement because of the deaths of those with whom the person has had relationships. After successive losses of friends and relatives, the aging individual often experiences a kind of anticipatory grief, actually grieving in advance for the companions who still live, grieving because they too will eventually die. These feelings are mingled with the fear of isolation, rejection, humiliation, loneliness, and the result can be intense anxiety or depression. In the elderly, anticipatory grieving can lead into a sustained disengagement from life processes. A limited amount of disengagement can be realistic, acceptance of and adjustment to a waning physical, psychosocial, and economic role. But there can be a limit to the amount of reduction in the quality of life a person can accept. There is a point at which the person's adjustment ability can be exceeded, and a severe depression sets in. It should come as no surprise, then, that the suicide rate among the elderly is twice as high as that for the population of the United States as a whole. A study of the statistics shows that the elderly person who attempts suicide is likely to be successful in his attempt, and is likely to take this action without seeking counseling or therapy of any kind. And so the picture emerges of an individual who has a genuine desire to die, rather than a craving for sympathy or attention. In addition to the characteristic of disengagement, the suicide-prone elderly person may have an intense concern with his legacy that reveals itself in preoccupation with such things as burial insurance. To avoid anxiety, the person often clings to habitual behavior patterns, tends to become somewhat automated, and regards change with suspicion and fear. Such rigidity can be functional because it minimizes situations where the aging person's diminished capacity will be tested. Compulsive behavior and projection are also common. The person may express his fear of loss symbolically by complaining that someone is trying to keep things from him, or by hoarding objects such as food, valuables, or even trifles. The highest incidence of depressive attacks is among men 55 to 65 and among women 50 to 60. They are most likely to occur after some major traumatic event or loss, such as the death of a close relative, retirement, or a crippling physical illness. In addition to overt suicidal acts, there may be covert suicidal behaviors, such as self-starvation, seclusion, self-neglect, and failure to follow a doctor's instructions. A patient who has a history of previous near-miss suicide attempts is, of course, at greater risk than someone without this history. The patient's remarks about suicide, either in the abstract or on a personal level, may also be revealing. The stage of depression is likely to be significant. When patients are extremely depressed, they may feel they are not worthy of the easy solution of suicide. But as they become somewhat less depressed, suicide may begin to appear to be an appropriate way to alleviate the pain of depression. Dr. Capel says that treatment of the elderly suicide-prone person involves three major considerations. First, managing the underlying depressive pathology. Second, keeping the patient alive until therapy can be effective. And third, improving those psychological, socioeconomic, and medical conditions that produced the stress that in turn activated the depression. The underlying depressive pathology is managed with either antidepressant medication or electroconvulsive therapy. Since ECT has the advantage of providing rapid improvement, Dr. Capel prefers it for patients in whom a 3-week wait for the benefits of antidepressant drugs would not be advisable. The usual procedure for patients who do not appear to be immediately intent on self-destruction is to start antidepressant medication immediately, while working the patient up for eventual use of ECT in case the medication is not effective in 3 or 4 weeks. Immediate hospitalization may be required to keep the patient alive until the therapy can become effective. Hospitalization sometimes also aids in relieving some of the environmental stresses that have contributed to the problem. During hospitalization, close management and supportive psychotherapy should be provided. Support and help from a relative can also be useful. Dr. Capel recognizes that socioeconomic or medical problems may be so severe in some cases that suicide may seem almost a rational response to an impossible situation. Sometimes there is not a specific psychopathology, but rather a decision based on reality that life has little to offer. The moral and ethical implications of this outlook are beyond the scope of this report, but Dr. Capel feels the physician should be sensitive to the possibilities for change in the environment with which the patient must cope. Although there may be no way for the physician to intervene directly in the environment, he may help to identify the difficulties and put the patient in contact with other support services.
At the sound of the tone, you may turn off the cassette and answer the questions on page 10 of your booklet, or you may run the tape forward to the end of the cassette and turn it over to proceed to the next report in the series. Conservative estimates have placed the number of incidents of child abuse in the United States at 200,000 to 250,000 each year. No one can accurately measure, of course, how frequently parents commit violent acts against their children. What little research has been done suggests that the problem is widely distributed among social and economic groups, and that parents who beat their children are often people who themselves were child abuse victims when they were young. Clinical psychiatrists constantly work to repair the damage wrought by violence within the family, while they feel the frustration of knowing that violent acts continue to sow the seeds of many of the neuroses and psychoses of the future. What can the clinician do to minimize the likelihood of child abuse by patients who show tendencies toward familial violence? Today in Psychiatry asked this question of Dr. Bruce Smoller. Dr. Smoller is a clinical instructor in psychiatry at George Washington School of Medicine and is in private practice in Bethesda, Maryland. As you listen to the following report on Dr. Smoller's views, you may wish to follow the graphic outline on pages 12 and 13 of your booklet.
Dr. Smoller developed a psychological theory of the causation of child abuse based on the concept of depersonalization, the type of character distortion in which an individual views his children not as separate human beings, but as a kind of projection or extension of his own needs or fears. The theory became the basis for a very decisive treatment plan that Dr. Smoller followed with 2 women who had strong tendencies toward child abuse. Upon follow-up, 18 months to 2 years after the initiation of treatment, the therapy appeared to be successful, both in terms of overall adjustment of the patients and absence of further child abuse incidents. Both Dr. Smoller's theory and his treatment procedure are best explained through a narrative of the 2 case reports. We will use the fictitious names of Alice and Betty to designate the patients. Alice was a middle-class mother of 2 daughters, aged 4 years and 18 months, when a series of incidents culminated in a severe beating of the 4-year-old. Alice had been in psychiatric treatment for about 2 years at that point. Some months earlier, she had sought help because she had found herself hitting the children with little provocation. Alice was depressed, and her marital relationship had been a stormy one, marked by an extramarital affair known to her husband, a suicide gesture, and a quarrel during which she fired her husband's pistol at a wall. During psychotherapy sessions, Dr. Smaller learned that Alice had been one of 5 children in an upper-middle-class family. She remembered her father, a physician, as a remote and distant man who was seldom at home, and whose expectations for Alice were much lower than for her brothers. She recalled her mother as obsessive and a bit disorganized. Alice remembered throwing tantrums as a way to get attention. Later, when Alice went away to college, she had academic difficulties, became pregnant, and dropped out of college. She then went into psychotherapy for a short while, but terminated it when she married a policeman whose socioeconomic background was quite different from her own. Dr. Smaller recommended that Alice be hospitalized immediately after the severe beating of the 4-year-old. He withdrew her antidepressant medication, and within a few days she became overtly depressed. During twice-a-week psychotherapeutic sessions, she angrily asserted that her husband, her father, and her therapist had hospitalized and then abandoned her. This sense of desertion reminded her of feelings about being sent away to camp as a child and to college in her teens, and was expressed dramatically several times later in the course of therapy. As Dr. Smaller helped her explore her relationship with her children and husband, she expressed the feeling that she received no gratification from the children, and complained that they did not respond to her as if they loved her. She related this to a feeling that she had not been loved or wanted as a child. Alice's references to her husband revealed that she related to him as a parent figure. At this point in therapy, Alice was allowed to leave the hospital on passes. She overstayed each of them, using her husband's work schedule as an excuse. Dr. Smaller then initiated a new phase of therapy, during which Alice was prohibited from passes, visits, and telephone calls. She became intensely depressed, and said separation from her husband gave her a feeling of impending death. But she also realized the absurdity of this idea, and related her feelings of abandonment to earlier incidents in which she had engaged in attention-getting behavior in response to a feeling of having been abandoned by her husband. She began to realize that she had perceived her husband as a substitute for her father, and therefore had seen her children as siblings who had competed with her for her husband's attention and prevented her from gratifying her unfulfilled infantile needs. After several weeks, Alice was allowed visits from her husband again, followed by passes outside the hospital of increasing duration. She was discharged after 5 months in the hospital, but weekly psychotherapy sessions continued for several more months. Alice was no longer depressed. There no longer were serious quarrels with her husband, and no further incidents of child abuse. Betty, the second patient, was a 31-year-old married middle-class woman. Unlike Alice, she had not actually beaten her child when she sought psychiatric help. But 5 weeks after the birth of her first child, she began having fantasies of throwing the infant out the window or down the incinerator or knifing him. She feared that she would not be able to prevent these fears from materializing, and began to feel sadness, with insomnia and early morning awakening. Betty was afraid to hold or care for the infant, and her parents took over care of the baby. When she sought help from Dr. Smaller, he began supportive psychotherapy and antidepressant medication, but the fears and the depression continued. Then he hospitalized the patient. In psychotherapy sessions, Betty recalled feeling lonely and homesick throughout her first 2 years of college and returning home every weekend. After graduation, she became an elementary school teacher. She remembered feeling distressed when she had discovered, just a few weeks after her marriage, that she was pregnant. She had experienced frequent nausea throughout her pregnancy. Nothing remarkable occurred during the delivery or the first 5 weeks of the postpartum period. As therapy progressed, it became apparent that Betty's marital relationship and the way she viewed her husband played an important part in her illness. Dr. Smaller began conjoint sessions with Betty and her husband twice a week. Betty began to realize she had been seeing her husband as an authority figure and had found it very difficult to express any anger toward him. She had been trying to curry favor with him by doing things that he liked and suppressing her own wishes. This pattern had actually recapitulated her own early relationship with her mother. Betty began to admit to viewing herself in competition with her child for her husband's attention. She saw ways in which her current family situation with her husband and child was intertwined with her earlier patterns of relating to her mother and younger sister, who had married and had children before Betty did. Betty remembered that soon after her baby was born, she had wondered, "If my baby gets sick, will my mother take care of him like she did my sister's baby?" As in the first case, Dr. Smaller banned visits between husband and wife for a while, thereby precipitating the separation that his patient had feared so intensely. Like Alice, Betty became extremely frightened and depressed and expressed rage at her therapist. But as therapy progressed, she began to understand and accept her feelings toward her husband, although she still found it difficult to express her hostility directly toward him. Soon her fears decreased and her depression lifted. After 2 months of hospitalization, she was discharged to outpatient care. A number of studies of child-abusing parents have taken notice of role reversal in the parent-child relationship, with the mother seeking love and nurture from the child. Dr. Smaller, however, found that both his patients were viewing their children as if they were siblings and were viewing their spouses as parental figures. Rage and resentment were directed at the child, both because the child was viewed as a competitor for the husband's love and because the mother was fearful of provoking rejection by her spouse and therefore did not express rage at him directly. Dr. Smaller felt that the familial relationship patterns of Alice and Betty tended to be self-perpetuating, and so he hospitalized his patients, forcing separations from the spouses in order to encourage the women to confront their feelings. He emphasizes that this must be done with great care, using a closed psychiatric facility with very thorough supervision. Dr. Smaller suggests that any psychiatrist with a patient who seems to depersonify the relationship with spouse and children should consider whether that patient has a potential for child abuse. He suggests asking direct questions of the patient about the possibility of violence toward the children, since the patient may not volunteer this kind of information.
At the sound of the tone, you may turn off the cassette and answer the review questions on page 14 of your booklet, or you may proceed immediately to the next report on the cassette. One of the basic maxims of family living is that parents are supposed to give love and attention to all their children equally, avoiding favoritism of any kind in their dealings with them. In a healthy, well-adjusted family, this role isn't seriously breached, since the parents relate to each of their children as a unique individual. But in families of neurotics, unequal balances of positive and negative feelings between parent and child are by no means uncommon. The very fact that equality of attitude toward offspring is such a popularly recognized principle in our society may make it more difficult for a parent to recognize and come to grips with the fact that he or she may hold one child in greater esteem and affection than another. This potent force in the familial relationship thus goes unrecognized and can wreak emotional havoc. This problem is a very common one in the opinion of Dr. Irving Bieber, a New York City psychoanalyst. As you listen to Dr. Bieber's views, you may wish to follow the graphic outline of the report on pages 16 and 17 of your booklet.
Dr. Bieber believes that feelings of preference for one of several siblings is quite common in families, and that it results in psychopathological consequences for the preferred child as well as the others. His description of the situation is based on experiences with a large number of his patients. The child who is treated preferentially by one or both parents is likely to be aware of the difference in preference at an early age, and is likely to perceive this as the result of some actual superiority he or she possesses over the other siblings. The preferred child is likely to develop grandiose mannerisms, acting superior to others in much the same way as did royalty, who thought of themselves as being inherently superior to the mass of mankind. The child tends to perceive the world as being comprised of those who are in and those who are out. To maintain his preferred position, the child works hard to excel in those areas perceived as being essential to superior status within the family. This might involve grooming or physical achievement through sports or neatness and politeness, for example. If the parent's value system stresses intellectual achievement, the child will probably strive intensely to be intellectually superior. This intense striving suggests feelings of insecurity about the child's status within the family, which may be engendered by the elements of ambiguity or ambivalence in the parent's feelings toward the child. The child seems to have some inherent sense of injustice concerning his parent's preferential attitude, and so his or her feelings of grandioseness are accompanied by guilt feelings based on the fact that the preferred child's special qualities are depriving the other siblings of their fair share of parental affection and support. The siblings who are not the preferred ones also develop intense and often unmanageable feelings as the result of their perception of the preferred treatment of the favorite sibling, according to Dr. Bieber. The non-preferred child tends to develop feelings of rivalry and hostility toward the favored child. In his or her overweening need for acceptance, the non-preferred child also seeks to excel in those areas valued by the parent, hoping to dislodge the rival and win parental recognition and love. This child, too, may develop the defense mechanism of displacement, directing hostility toward the favorite child and then feeling guilty about relegating that child to the status of a second-class or inferior being. Dr. Bieber says that he has seen the problem occur as the result of one parent's preferences and also when the preference is shared by both parents. When the preference patterns of the two parents differ, this may result in a child developing both the patterns common to preferred children and those that are characteristic of non-preferred children. For example, the child who is the mother's favorite may feel grandiose over the artistic or dramatic traits and skills perceived to be valued by her, and at the same time harbor feelings of inferiority related to not having the physical attributes valued by the father who prefers an athletic sibling. The results of these relationships in terms of neuroses and symptoms depend upon the entire combination of factors operating in the family situation. Dr. Bieber says that problems of gender identification and sexual functioning are likely to arise when the father shows very intense preference for his daughter and the mother shows a strong preference for her son. The son in this situation may develop the wish to be a woman in his rivalry with his sister for the father's love, and the sister may wish to be a boy. The family relationship becomes complicated in a somewhat different way when a husband or wife relates to the child in preference to the spouse. Some parents are prone to exploit the favored child in an attempt to fulfill some need that the spouse is not fulfilling. For example, if the parent's ambitions for career achievement have been frustrated, a child may be selected who is seen as likely to fulfill lost dreams and fantasies. The stage mother is a well-known example. A woman who is sexually insecure may select an attractive daughter to act out wishes to be the belle of the ball. A father who is uncertain about his capabilities may strive for power and position through his son, perhaps in participation sports. A child who is preferred over a parent is likely to be aware of the preferential relationship, and the result, as with siblings, is likely to involve guilt. The child then feels personally responsible for having disrupted a parental relationship. Dr. Bieber has found that the child who feels this sense of guilt is likely to harbor an unconscious fear of retaliation, and if the child feels insecure or inadequate, he or she may feel a desire to renounce the role to avoid a crisis. Thus, a girl who believes her father prefers her because she is prettier than her mother, or a son who thinks his mother prefers him because he is better looking than his father, may become fearful of appearing attractive. A child faced with this threat may masochistically sabotage his or her good looks by overeating and becoming obese, or by engaging in any of the other self-destructive activities frequently seen in psychiatric patients. The results of parental preference most often become visible when a patient is being treated for problems which have other, more obvious, immediate causes. In therapy, Dr. Bieber advises, it is necessary to bring the patient to a realization that parental preference is not based on the individual's true superiority, but is an expression of parental neurosis, usually involving a transference reaction to a favorite person in the family history. If psychotherapy proceeds well, the patient will come to understand the irrationality of playing favorites and the results that this behavior produces in the children. The non-preferred child who believes in his inferiority as firmly as the preferred one believes in his superiority must be convinced that his lower status in the family represents a defect not in himself, but in his parents.
At the tone, you may turn off the audio cassette and turn to page 18 of your booklet and complete the review questions based on this report. This series of reports has been brought to you by Abbott Laboratories. This concludes our presentation.